Hi, everyone. I want to welcome you to our Eating Disorders Awareness Week 2023 Professionals Panel. My name is Dr. Stacey Nye, and I am the Director of the Psychology Clinic here at UWM. We are so thrilled that you could join us today. We have a very interesting and exciting program for you. I want to just briefly tell you that we're going to do a brief introduction of all of the panelists, and then we're going to answer the questions that were submitted through the registration. And the chat has been disabled just to limit the, number and kind of talking going on behind the scenes so that, the panelists can concentrate. So just sit back and relax and let us do all of the talking now. I want to introduce one of our students here at UWM who will be our moderator for today, Amy Wang. Take it away, Amy.
Thank you for the welcome introduction, Stacey. So I will be introducing our panelists today. So we have Dr. Stacey Nye, who just spoke. Dr. Stacey Nye earned her doctoral degree at Northwestern University Medical School. She is the director of the UWM Psychology Clinic and the Eating Disorder Specialty Clinic. Dr. Nye opened Nye Psychotherapy in Mequon, Wisconsin 5 years ago and has been in clinical practice for over 30 years. Additionally, Dr. Nye has been interviewed on local and national news stations regarding her expertise in eating disorders and body image issues. She has conducted numerous professional and non-professional seminars, trainings, and workshops, as well as authored book chapters, research papers, and journal articles. So thank you for being here, Dr. Nye. Next up, we have Sara Gonzalez. Sara graduated from Mount Mary University with a degree in dietetics in 2018. She has been with Rogers Behavioral Health for over 4 years, working specifically with the eating disorder population for the majority of this time. Having personally experienced disordered eating patterns and other mental health struggles herself, she is very passionate about the work that she does. Outside of work, Sara enjoys spending time with her boyfriend and 2 cats. Sara loves reading, crocheting, and being outdoor as much as she can. So welcome, Sara. Next, we have Dr. Kelly Wahlen. Dr. Kelly Wahlen is originally from the Milwaukee area and earned her undergraduate degree at the University of Notre Dame. She then earned her medical degree at Boston University School of Medicine and completed residency at the Harvard Longwood program. After practicing for several years in academic, outpatient, partial hospital, and crisis service settings, she joined UW Milwaukee in 2017. She evaluates and treats patients with a broad spectrum of mental health concerns, including mood and anxiety disorders, ADHD, psychosis, and eating disorders. She appreciates the complex relationship between biological and psychosocial contributors to mental illness and focuses on a collaborative care with patients and the dedicated team of clinical professionals at UWM. And last but not least, we have Anne Schmidt. Anne is a nurse practitioner at the University Student Health and Wellness Center. Anne Schmidt earned her bachelor's in nursing from Marquette University and attended UWM to earn her master's in nursing to practice as a nurse practitioner. Anne has been with UWM Student Health and Wellness Center over 20 years. She evaluates and treats patients with a variety of medical problems that had seen in the college setting, including women and men's health issues, respiratory, dermatologic, and orthopedic. She is the main provider at the Student Health and Wellness Center that treats patients with eating disorders, and loves the energy of the college population where she can use her skills to treat, educate, and work with the students in order to live healthier lives. So those are the 4 panelists we have today. So we're going to dive right in with the main topics of today. We will start with having our panelists introducing what is their primary role in helping patients with eating disorders. And we will start with Stacey.
Hi. So my role in working with patients here at UWM, I'm the clinic director. So we have clients who come in and have screenings, and then we decide if they might be a good fit to be treated here at UWM by one of our graduate students. In my clinical practice, as my role as a psychologist, I do the person who does the main therapy. So I oversee the treatment. I might talk to all of our various panelists here in their role to coordinate what treatment would look like. So I might talk to the psychiatrist, I might talk to the nurse practitioner, talk to the dietitian, so that we're all on the same page about how therapy is going. And I see the therapy through from beginning, middle to end.
Thank you, Stacey. How about you, Sarah?
Yes, thanks for that warm welcome, first of all, Amy. My primary role as a registered dietitian, I work on the inpatient unit here at Rogers. Primarily, what I work with patients on is making sure that they can eat an adequate amount of food. So we work together on making sure they're getting enough calories and how that will look as far as what they're most comfortable with. Over time, too, I help patients overcome some of their feared foods by introducing some of those more challenging foods, working on food exposures to reduce that anxiety with those foods. Also, I do talk about weight with patients at times too, helping to sort of reduce the anxiety and talking about those numbers and get some more perspective on what are normal weights, normal weight trends, and kind of trying to break a lot of the diet culture related myths that are out there.
Thank you, Sarah. How about you, Kelly?
Sure. Since some audience members might have some confusion about the different roles and titles, I'm a psychiatrist. A psychiatrist is a physician who specializes in evaluating and treating mental health conditions. At UW Milwaukee, we have a medical clinic and a counseling center that are co-localized in our Student Health and Wellness Center. And this is where I provide psychiatric care on an outpatient basis for undergraduate and graduate students. In that role, I primarily conduct evaluations for patients who self-refer or who are referred by another clinical provider. And they might be referred because of mental health concerns. That includes eating disorders. And this is particularly important because across the UW system, when students are filling out sort of questionnaires when they present to counseling centers, we see about 24% of students are endorsing some concerns about eating, weight, or body image. That's roughly consistent with national averages. The data is from about 2020. So I don't think we'll see it nudge down anytime soon with the pandemic. But my role is, if people are screening in advance of the appointment or during the appointment, if they're expressing some concerns about disordered eating patterns, my goal is to delve into that a little bit more. And then, of course, we know sometimes patients are not necessarily recognizing or not wanting to be forthcoming about some of those concerns. And so part of that psychiatric evaluation also is being able to recognize some signs and symptoms of eating disorders that might require evaluation immediately or longer term. And then part of that diagnostic process involves sometimes applying specific labels like anorexia, bulimia nervosa, if they apply, evaluating for level of care. And most of our patients will continue to work with on an outpatient basis, but sometimes if people are too medically ill or if we have safety concerns psychiatrically, we'll refer for a higher level of care, which can include inpatient admission or intensive outpatient programs. Part of the ongoing treatment for psychiatry in an outpatient setting would be ongoing evaluation and assessment of where someone is at with their eating disordered behaviors, where they're at with medical stability. And then certainly there can be a role for medication. And so evaluating the need for medication and adjusting it accordingly over time becomes a part of the treatment too.
Thank you, Kelly. And last but not least, Anne.
I'm a nurse practitioner here, and I'm one of the main providers that see the majority of eating disorder patients. So My main role is to perform a thorough assessment and physical exam. I really want to evaluate the general health of the patient. And I need to determine if the patient is medically stable to continue care at UWM. And like Dr. Wahlen alluded to, some of our patients will need a higher level of care. And sometimes that comes from me from a medical standpoint, and sometimes that may come from a psychiatric standpoint, just depending where that patient is. And then if the patient is stable medically and mental health, we're able to work together as a team with our psychiatrist, our psychiatric NP, therapist, and our registered dietitian. We're able to work as a team. And then, of course, I work with the patients in regard to their medical issues that may arise from an eating disorder, or maybe their medical issues that they already have. So each plan is really individualized. So it really depends how often I see that patient, on their eating disorder, but we develop a plan together, and then I see the patients as needed.
That's wonderful. Thank you, everyone. So now we have a general understanding of their roles with patients with eating disorders. We're going to go into the individual questions for our panelists. So we'll have our panelists taking questions in turns, and we'll start with Stacey again. So Stacey, what kind of treatment is best for eating disorders?
So that's a very broad question, and I'm going to just start by saying that it depends on the eating disorder, and it depends on how long someone has had an eating disorder, and it depends on how severe their symptoms are. So, for example, different levels of care that Anne just referenced, starts with outpatient treatment, where you might just go and see individual providers, for an hour here or an hour there. And that's often a good place to start with treatment if, you're new and you're medically stable already. And if you've been struggling for a while and things aren't getting better or maybe even getting worse, then you might be referred to a higher level of care like intensive outpatient or a partial hospital. And other examples might be if you have, if that's not working for you, or you just need some more support, maybe you need more meal support, or maybe you need some medical support, then you might be referred for inpatient or residential. So it really depends on, what you're coming in with. But besides that, there's also different kinds of treatment that you might receive for your eating disorder. So I would say that the first recommended treatment for an eating disorder is cognitive behavioral therapy, where you're looking at the ways in which people with eating disorders think and the way in which they behave and certain emotional dysregulation issues they might have. So cognitive behavioral therapy looks at all of those components, and that's really used for all eating disorders. Also, specifically, we might use for adolescents with eating disorders, we might use something called family-based therapy, where we bring the family in to really help work on, getting people stabilized with their eating at home. We might use dialectical behavioral therapy if people are having severe emotional dysregulation issues. So it depends on what you're coming in with, and that's something to, talk to your individual therapist about, what kind of treatment they're going to be using with you and why. So.
Thank you, Stacey. That really gives us a very comprehensive understanding on how to approach treatments. So the next question is for you, Sara. That has to do with your role as a registered dietitian. So how do you create a meal plan?
Yeah, so it really depends on what the individual has been struggling with outside of the treatment setting. With every single person I work with, I try to meet them where they're at. So if I have somebody who has been restricting pretty severely at home, they're not eating very much, maybe eating one meal a day, I will work with them to figure out, okay, how can we get you back into a normalized sort of meal plan structure where you're eating multiple times a day. Maybe it's not going to be full meals or full snacks a day, but we work first on getting that structure down. For individuals who struggle more with binge eating, We also want to have a pretty structured, stable meal plan for them to be able to follow to kind of break those habits. So we work with them on making sure that they're not feeling hungry, but they're not feeling overly full. So again, creating that stable, structured sort of way to eat, and then working from there to kind of make it more normal over time.
That's great. Thank you, Sarah. The next question's for Kelly. For your expertise, a lot of people are interested in, are there any medications that treat eating disorders?
The short answer is yes, there are medications that can be helpful in treating eating disorders. The longer answer is a little bit more nuanced than that. Just to underscore some things that have already been said. Standard and best practice would be to have a team-based approach to treatment. So it'd be pretty rare to have medication treatment be the sole treatment modality that we're utilizing in an eating disorder. Typically I would want someone like Anne involved in in the care of my patients, certainly dietitian and a therapist. The importance of therapy, even when there's medication involved, is really important. We see better outcomes. And more specifically, though, if we are looking at medication and what sorts of medication could be helpful, it depends on the circumstance, and constantly we're looking at balancing benefits versus side effects. Medicines that can be used include SSRIs for bulimia nervosa. For instance, fluoxetine is an example of an SSRI. In binge eating disorder, we might also use a similar medication, or a different one like bupropion, which is a different type of antidepressants. But again, when we're looking at thinking about benefits versus side effects, bupropion is going to lower seizure threshold. So if we have any concerning about purging, or maybe someone not disclosing purging, laxative abuse, other things that might contribute to electrolyte abnormalities, or things that could lower a seizure threshold, it wouldn't be safe to use that medication. Vyvanse or lisdexamfetamine, which is a stimulant, could also be considered for some patients with binge eating disorder. However, it's a controlled substance, has a potential for misuse, abuse, diversion, can be associated with cardiovascular side effects. And so patient selection, monitoring, and clinic setting or type are especially important to consider prior to recommending a medication like this. Regarding anorexia nervosa, psychotropic medication would not be an initial or primary treatment recommendation. The evidence simply wouldn't support it. Nutritional rehabilitation and psychotherapy would be the primary treatment modalities initially. However, if there's significant comorbid depression or anxiety that persists, despite reasonable weight restoration, evidence would support trial of antidepressants. For patients who are kind of acutely ill and not gaining weight with nutritional rehabilitation, we could consider a medication like olanzapine, which is an atypical antipsychotic that can help with weight gain. However, anytime a medication is introduced in low weight patients, we have to be careful. The dosing is done cautiously. There's a depletion of body protein and fat, which can result in increases in serum concentrations of medication. There's medical complications of anorexia nervosa that have to be considered, like low heart rate, low blood pressure, long QT syndrome, which is related to the heart rhythm. So any medications that might worsen these complications or that might prolong cardiac conduction, they use very cautiously in malnourished patients. Additionally, across all eating disorders, we have to be aware that starvation, vomiting, dehydration, excess hydration can all impact drug absorption and toxicity, and that necessitates additional caution. So in all of these cases, there are discussions about risks of medication, about potential side effects, including impact on weight and appetite. And again, we want to think about the benefits outweighing the risks.
That's great. Thank you, Kelly. The next question is for Anne, which is kind of related to what Kelly talked about, how this is a multi-dimensional involving multiple roles of the care team. So for Anne, what is done at an initial medical visit for a patient with an eating disorder?
Sure. So when a patient first comes into the health center on campus, they can expect to be here about a good hour. We initially do their vital signs, which includes a weight, but we do blind weights, which means we turn the patient around so they don't have to look at the scale, because I need a baseline. I need to know where they're at. And then I sit with the patient and I do a really thorough history. I really want to know about their eating disorder, when it started, the length of it. So what I'm, like the focus of it. And then I'll look at what we call a social history. I delve into their alcohol, tobacco, illicit drug use. I ask about exercise. There's something called compensatory exercise, which is exercise basically that's done to make up for calories eaten or consumed. So it's almost in an unhealthy way. Someone's exercising to maintain a low weight or to continue to lose weight. I do a diet recall. I'm not a dietitian, but I want to get a good sense of the calories that they're eating, whether it's overeating or under eating. Along with that, I ask about habits, binging, purging, diet pills, laxative use, diuretics. I ask if the patient's weighing themselves or their food, if they're doing body checking or looking in mirrors multiple times a day. I also like to know about their background. What's their major? What's their employment? Do they have significant others, a support system? Kind of want to really get a whole sense of the person. I think that really, mental and medical health, I always tell my patients, they're always combined when it comes to eating disorders. It's really hard to separate them. I will then go into their past medical history. What are their mental health issues? What are their medical health issues? I look at a family history. We know patients with a history of eating disorder in their family have a higher risk of having an eating disorder. And then, of course, I do a basic head to toe exam, what you would expect to have done in a provider's office, everything from, eyes, ears, nose, throat, heart, lung, a GI exam. I then look at an EKG. On most of my patients, I want to really know their heart evaluation, and I do blood work. Some of the blood work we'll look at a CBC to rule out anemia or iron deficiencies. Look at metabolic panels, super important to know the electrolytes, the kidney function, the liver function, the blood glucose, other things like thyroid, urine test. Then basically I take all these tests and then an evaluation, and I kind of get a good sense of, the health of that person. And then we kind of develop a plan from there. But I think it's important to note what I tell my patients, this is where you are now medically today. These are the labs you had today. And unfortunately, with some patients, maybe with anorexia that are really doing a lot of caloric restriction, you can see these labs change quite quickly, which can be dangerous. So again, everyone has their own individualized plan based on where they're at the time.
That's wonderful. Thank you, Anne. So we'll now circle back to Stacey. The next question is for you. What racial, ethnic, or gender disparities exist?
So, while it might be assumed that eating disorders only happen to young, rich, white girls, actually research is showing us something different, that they're just as common in people of color than in white individuals. So what we're finding, though, is that people of color face a lot of barriers to accessing appropriate diagnosis and treatment due to, cultural stigma, language barriers, lack of representation, lack of access in the healthcare system. So, I think that we've done research over many years, not recognizing where eating disorders might exist in other populations. So research is really lagging behind the reality of where eating disorders exist. What we do know, though, in more recent research that we've done, research suggests, first of all, for gender, that certainly more women are diagnosed with eating disorders than men. Again, we don't know if this is due to, the stigma associated with eating disorders and men not coming forward and probably not being asked or diagnosed as often. Current statistics suggest about 1 in 4 clients with an eating disorder are men, but again, that might be an underrepresentation to the reality. We're also finding more eating disorders among people who identify as lesbian, gay, bisexual, or transgender. And this may be due in part to the fact that LGBT individuals face higher rates of discrimination, stigma, and social isolation, which can contribute to body dissatisfaction and disordered eating habits. Also, socioeconomic status. So we have found that, eating disorders are more common among individuals from higher socioeconomic backgrounds. However, again, this might be due to the fact that eating disorders are often underdiagnosed and undertreated in lower income communities. And newer research coming out is demonstrating that we do find eating disorders even in people who are, food deprived. So a lot more research has to be done in terms of, where we're seeing eating disorders and what some of the reasons are, and recognizing that eating disorders can affect anyone, regardless of their race or ethnicity or gender or sexual orientation, socioeconomic status. So really understanding that while some groups might face barriers to accessing appropriate diagnosis and treatment, I think is really important to help, reduce the risk for these kind of negative health outcomes associated with eating disorders in those populations.
Okay, thank you, Stacey. The next question is for Sara. So how different are meal plans based on the type of eating disorder?
So I kind of touched on that in my previous question as well. Really, the most kind of the basic way to think of it is creating that plan that will be 3 meals, 3 snacks a day, creating that structure that kind of goes for most eating disorder diagnoses across the board. For those struggling more on the side of binge eating, it's more of like, how do we get to a normal, consistent eating pattern rather than kind of reinforcing often binge restrict cycles that are going on with that. With individuals who are restricting a lot, we again start with a smaller meal plan, and then we gradually build up to first a normalized meal plan where it's just like adequate normalized nutrition. Beyond that, we work on increasing how many calories they're taking in to ensure that they are restoring an appropriate amount of weight as needed. When we are looking at that here at Rogers, we typically are aiming for roughly like a 2 to 4 pound rate of weight restoration each week. So we monitor weight every day and every week to make sure that our patients are fitting within that. And then if we need to is when we would tell them, hey, we need to add more food or we need to add a scheduled supplement. And it would be a very similar approach in an outpatient setting as well too, obviously not quite as strictly monitored, but same idea of making sure that intake is meeting that individual's needs.
Sounds good. Thank you, Sara. The next question is for Kelly, which is a follow-up on the previous question about medications. So what kind of medications can be helpful in treating coexisting conditions?
It's a tough one because there are a lot of coexisting conditions, and I could probably take us into tomorrow talking about an array of medication strategies across all these conditions. But I will try to highlight or summarize a few of kind of, I guess, some takeaway points. First of all, it's important to recognize and identify coexisting conditions, because when another psychiatric condition is present along with an eating disorder, the outcomes are worse and the mortality is greater. And with anorexia nervosa, for instance, we already have the highest mortality rate across any psychiatric illness. And so if there's a comorbid illness along with it, we want to be able to identify and treat it. In general, the goal would be to reach solid symptom control, to optimize safety, and once again, to balance benefits and side effects. So some common coexisting conditions would include depression, anxiety, OCD, PTSD, and for each of these conditions, SSRIs, selective serotonin reuptake inhibitors like the fluoxetine that I mentioned, escitalopram, sertraline, it would be reasonable options. SNRIs or serotonin and norepinephrine reuptake inhibitors would also be reasonable. Other non-SSRI antidepressants can have a role. I already touched upon bupropion, but another example of a medication that we might consider is mirtazapine, which can be helpful for depression and anxiety. It can help to increase appetite, decrease nausea, facilitate sleep, and really capitalizing on those side effects can be really helpful when working with an individual who's willing or wanting to have a higher appetite. An example of a patient who would fall in that category is someone who might not have anorexia or bulimia, but an unspecified eating disorder, some eating disordered behavior. For instance, some food restriction that really results from a fear of vomiting related to anxiety. And it's that kind of a decline in body weight that's very ego dystonic, or not at all what a patient wants, but their anxiety is getting in the way of eating. And in a patient like that, increasing appetite, decreasing nausea can be really, really helpful. However, a patient with anorexia nervosa, increasing their appetite can induce a lot of distress. And so any of these any of these decisions are made with really careful discussions with patients. Another example of an eating disorder, a comorbidity would be ADHD. Individuals with eating disorders are more likely to have ADHD than people without an eating disorder. Effective management of ADHD can include therapy, but it can also include a stimulant or non-stimulant medication. But we have to be careful because of cardiovascular side effects and the anticipated side effect of decreased appetite. So again, when thinking about managing the ADHD with medication, we have to be careful and understand what the status of the eating disorder is. There's another class of medications called atypical antipsychotics. It's kind of an unfortunate label that's applied to this class of medications that can be helpful in many conditions in addition to psychosis. So they can be useful as mood stabilizers in bipolar disorder. They can be used adjunctively in the treatment of depression or anxiety disorders, and especially can help to decrease the impact of intrusive and obsessional thought patterns. And the potential for weight gain and metabolic side effects with these medications, though, has to be considered carefully in the context of an eating disorder type. So if a patient has psychosis or bipolar disorder, and I'm considering adding a medication like this, and there's an eating disorder, once again, it's a careful discussion and careful monitoring that would occur.
Thank you, Kali. That really is a very complicated question, and it's probably going to be very depending on what the situation one individual is experiencing. So the next question we have is for Anne, which is kind of related to what Kelly was talking about, is that what are some of the medical complications of eating disorders?
Well, unfortunately, eating disorders can affect every system in the body, and there can be a whole discussion on that and the complications alone. But I think touching on a few, I would say the gastrointestinal system or the GI system has the most universal complications. There's something called gastroparesis or delayed gastric emptying, where basically the bowels just slow down. So it can cause a lot of discomfort. Patients can have constipation, bloating, and nausea. So here you have an anorexic patient that you're trying to get to eat more often, and they have these symptoms. So it's kind of a battle because that you have to learn how to eat again, maybe, or learn to eat small meals more frequently. So that can be a struggle. Cardiovascular system, you may see a decreased heart rate, a decreased blood pressure, arrhythmias, which means a irregular rhythm. And obviously those can be very serious if your heart rate goes too low or your blood pressure goes too low. For women, the GYN system, you may see a regular menstrual cycle or even a complete loss of their menstrual cycle because of low body weight, low fat, and low estrogen. For the endocrine system, osteoporosis or stress fractures may occur because you have a loss of bone density because of decrease in nutrients. Along with this, you may see a low blood sugar, and because of that, fatigue, lightheadedness, even fainting or dizziness. So that those may even be disguising some eating disorders. So it's really important to ask patients that maybe aren't even a known eating disorder, why this college student I see may be dizzy, because there may be other reasons behind that. Hematologically, you may see anemia and iron deficiency anemia. Dermatologically, skin changes, hair changes, maybe really dry skin, dry hair. Hair can even fall out. Musculoskeletal, you may see muscle wasting, where you lose your muscle pretty much because of lack of nutrients. Neurologically, you may see, I think Dr. Wahlen alluded to it, you may see a higher seizure or lower seizure threshold, so you're more likely to get a seizure. And also cognitive impairment. So a depressed person or anxious person may become more depressed, more anxious, more moody, or just more emotional in general. And then maybe lastly, the oral health. So a patient that purges or vomits often can really destroy their enamel of their teeth to the point where you may need to have some teeth removed. So that, that's pretty sad. Interestingly, I attended a virtual conference back in the fall, and one of the medical people that were speaking, he mentioned that we really need, and this was his thought, but we need to normalize weight before we can normalize behavior and thinking. So his thought is we need to have that normal weight before we can treat our anxiety, our depression, or our other mental health issues, because otherwise they have to connect together. So brain has to follow the body. So obviously, like I mentioned earlier, medical and mental, it goes together. So there's so much that can happen with the body. So thank you.
Thank you, Anne. The next question is a big question, and many are very interested. It's for Stacey. So what causes eating disorder?
So there's so many things that come together to cause an eating disorder. There's no one thing that causes them, but a whole dance of things might come together. So we refer to this as the biopsychosocial model. So bio is first. We're really finding that genetics are strongly influenced in causing eating disorders. So if you have a relative with an eating disorder or another kind of, condition like depression or anxiety, that increases your risk to develop an eating disorder. A history of dieting causes eating disorders. So that's the number one thing I tell everybody: dieting causes eating disorders. So many numerous reasons why restricting and, putting your body into, malnutrition really is going to push you to want to, overeat. And then you're going to want to purge to get rid of the calories. That's a whole conversation, as everyone's saying, in and of itself. And just in general, like not eating enough causes people to, as I was saying, maybe overeat. People with, type 1 diabetes might be at higher risk. Like a quarter of women with type 1 diabetes develop eating disorders. So there's, and more that I haven't even mentioned yet. So biology is relevant. Then there's psychology. So there's certain personality traits that we see in people who develop eating disorders. So if you are particularly perfectionistic, that's a really strong risk factor for developing an eating disorder. You might be perfectionistic about your grades or tidying up at home, but if you begin to become perfectionistic about the way you look and your body, and then your body image, you bring that into that, you feel bad about the way you look, this now really increases your risk factor for developing an eating disorder. You might have, excuse me, sorry for coughing, an anxiety disorder, where, you feel nervous and anxious, and maybe you have some social anxiety, or, again, like anxiety about, eating in public, things like that. That increases your risk for developing an eating disorder. Or just like kind of like rigidity, like mental or behavioral rigidity in general. So I I haven't done this yet, but I want to put a big sign up in my office that says flexibility is best, because anytime we're rigid about the way we think about things, it leads to problems. So in particular, when it comes to food and eating and the way we look, if you're very rigid about the way you think about those things, then you increase the risk of developing an eating disorder. Now the social, on the social end, obviously we live in a culture that, youth, thinness, and beauty are highly, highly valued. And there's a very narrow or rigid way of defining those things. So that leads to weight stigma. People at a higher weight are stigmatized in our society, both by peers, by family members, and by the medical community. And I might get a chance to talk about that in a little bit. But that kind of stigma leads to teasing and, internalizing this thin ideal. So I don't know many people who are immune to that, internalizing that thin ideal that we have in the society. You can learn to have that not matter, but if you've internalized this, oh, I have to look a certain way in order to be beautiful, or I have to look a certain way in order to be accepted, you are now at a higher risk for developing an eating disorder. Also, there's historical and intergenerational trauma. So there's, a lot of trauma that occurs, I don't know if you all are familiar with the phrase, historical or intergenerational trauma. So things like, racism, systemic racism is passed down from generation to generation, and people feel, the trauma of that, even if they haven't themselves experienced any racist acts. Although I can't imagine anybody going through, our culture right now and having not experienced some kind of, racist acts. But that the stress from that can lead people to, develop eating behaviors, unhealthy eating behaviors, or, bad feelings about themselves that can, put them at risk for developing an eating disorder. So again, not any one of these things, because we all live in this culture where, thinness is idealized. Not everyone develops an eating disorder. But if you start to have some of these things all together, like, oh, you're 16 years old and you're in high school and everybody is talking about being thin and wearing like tight jeans, and you're particularly perfectionistic about the way you look. And I didn't mention family, because families are living in the same culture we are. But if you're living in a family where, people are talking about being thin and dieting, now you've got 3 of those kinds of risk factors. Each one puts you at a higher risk. So those are some of the causes that lead to eating disorders.
Thank you, Stacey. That's always a big question to tackle. So many facets, like you mentioned. The next question is for Sara again. A more specific question about how do you set a target weight?
Sara, did you hear Amy?
Oh, I think Sara might be freezing.
Yeah.
In the meantime, Stacey, would you like to take another question?
Sure.
We
Hopefully
wait
Sara will
for
come
Sara
back.
to log back on.
Yeah.
So another question that I have for you is, what are your thoughts on the new AAP guidelines for children categorized as obese? And what are some of the supports around that?
So I hinted that I might get a chance to talk about this already today. And I want to say that these are my personal opinions, and I can't speak for anybody else or UWM or Rogers or Counseling Center or anything like that. But I will say that I'll just very briefly say, so these new AAP guidelines are the guidelines recently put out by the American Academy of Pediatrics, and their comments on guidelines for treating childhood obesity. And the AAP has advised pediatricians to offer treatment options early and at the highest available intensity. This is a really strong statement that they have put out. And they made suggestions about this approach should be used for kids age 6 and older, and recommended even possibly for children as young as 2 and their families. And they're recommending some very intensive treatment. And if treatment doesn't work, possibly weight loss drugs need to be considered for adolescents as young as 12 years old. And if that's not enough, then teens 13 or older with severe obesity should be evaluated for weight loss surgery. So these guidelines are problematic for a number of reasons. First of all, these guidelines and recommendations are based entirely on the use of BMI, or body mass index, as a diagnostic tool, which has racist origins and was never intended to be used for the diagnosis of individuals. I could talk for an hour just on that, but I'm going to go on just in the interest of time. Research cited in these recommendations are not robust and do not show signs of long-term outcomes. So I want to say that there's no long-term treatment for obesity. Dieting does not work on a long-term basis. Weight loss drugs do not work on a long-term basis, and weight loss surgery does not work on a long-term basis. So the rate of relapse and weight regain is really quite high with all of those conditions. The recommendations also are made, they perpetuate weight stigma. And I have just countless examples of clients and myself of going to the doctors and being put on diets to the point where people don't want to go to the doctor anymore. People don't want to get on the scale. People avoid the medical community because of the pressure and no real solutions that's given to people. So just telling someone you need to lose weight, is really unhelpful. And doing that to a child that in and of itself, I should have mentioned that before, it's one of the causes, that in and of itself increases the risk of developing an eating disorder. So we're going to share in the chat. I have some areas where you can get some extra support. The Coalition for Eating Disorders has a really helpful website. So Amy or Maddie is going to put that in the chat and share with you some great resources to that. So thanks for asking that question.
Thank you, Stacey. And I will be putting the resources in the chat in just a bit. While we do that, we have Sara back. So Sara, a question for you is, how do you set a target weight?
Yeah, that's a really good question. So I work primarily with children and adolescents. So what we look at as the gold standard really is getting a copy of each individual's growth charts and taking a look at how they grew early on in life, or at least before the onset of their eating disorder. We like to try to get a sense of what was normal for them before the eating disorder kind of came in and disrupted things and changed what their growth patterns might have been otherwise. For young adults as well, usually people between the ages of about 18 to 25, we can more or less extrapolate from those growth charts as well and kind of get an idea of where somebody might need to be. For adults, and really for anybody, other considerations would be weight history as far as what was a past high weight, what was the past lowest weight. For females, what is menstrual threshold? So did they lose their period at a certain weight? That, of course, also does not necessarily tell us if somebody's at an appropriate weight or not, but it is one thing that we can look at. The biggest things that we look for clinically are that somebody is much less preoccupied with their weight, with their appearance. They're not engaging in behaviors. Their labs, their vitals are stable, really looking for overall stability. So we try to come up with a number that will make the most sense. I know we always use a range because it's doesn't make sense for anybody to have one set number that's going to be perfect for them forever. but we try to get an idea and then base our level of recovery on how they're presenting clinically, if that makes sense.
Thank you, Sarah. We want to be mindful of time here, so maybe just some last questions for Sarah here that has to do with child and adolescence. And before we dive into those, there's one question for you, Sarah, is that what would you like primary care physicians to know about eating disorders?
That is my favorite question in the world. And we did touch on it a little bit already. Stacey did. The biggest thing I would want primary care physicians to know really is to be gentle and considerate with any sort of weight discussions that they might be having. Ideally, I would love for all doctors to have more education in weight science, the whole concept of weight stigma, everything that we sort of talk about every day. But knowing that we're quite a ways away from that realistically, what I would like for primary care physicians to do, at least if they do have a weight concern, don't talk about it in front of the child. Pull the parent aside and have a discussion privately and find a way to talk about things that aren't going to trigger anything or upset the child.
Okay, thank you, Sarah. I think we might have time for another question. A lot of people are very interested in, eating disorders and children and adolescents. So what are some of the warning signs for students in middle school or 6th to 8th grades? How can the school support in the process of identifying and the treatment for eating disorders in that age group?
I would say the biggest things to look for would be any sort of changes from an individual's baseline. So a lot of times what we might see is dropping grades, or maybe somebody that used to be very social and like to hang out with friends, go out to eat with friends, those behaviors kind of stop. Things that teachers or counselors and things might notice at school would be kids just skipping lunch periods altogether or throwing their lunches away. That's something that's very common. Those are the biggest things that I would look up for. Another thing too could be spending a lot of time in the bathroom, like immediately after lunch too. It's possible that kids could be trying to purge after lunch as well.
Thank you, Sarah. And I think we're at time. So thank you to our panelists. Stacey, would you like to give a closing remark?
Yeah, I want to thank all of our panelists today for taking the time to help educate people about eating disorders. I want to thank all of our participants who have signed up and watched us live, or who are maybe going to watch our video afterwards. We had an overwhelming number of questions, so hopefully, I know we didn't get to all of them, but feel free to reach out. We've shared some resources here today. If you have, I can see that there's further questions coming up, but I'm really sorry that we don't have time to answer the rest of them. But I also want to thank Rogers Behavioral Health for sponsoring our event, and the UWM Health and Wellness Center here, formerly known as the Counseling Center. They've been really helpful. And, this has been recorded, and it's going to be on the UWM Psychology Clinic website. You can see that's the first one under events. So please make a note of that and come back and share it with people that you know. And feel free to reach out to us if there's anything else that you need. And thanks very much for attending.